Hello.
Hello, sir. Good afternoon.
Good afternoon.
I am referring patient Rodrigo de la Cruz, 50-year-old male, who was diagnosed with femoral neck fracture left and for partial hip arthroplasty left tomorrow at 7 a.m. under Dr. Ronquillo. Allegedly, this patient fell 2 days prior to consult.
What is anesthesiology? It is the practice of medicine dedicated to the relief of pain and total care of the surgical patient before, during, and after surgery. Anesthesiologists are physicians specializing in perioperative care, developing anesthetic plans, and the administration of anesthetics. But aside from administering anesthetics during surgery, there are other roles anesthesiologists fulfill, and those are perioperative care of the surgical patient, sedation during diagnostic procedures, resuscitation, pain management, critical care medicine, and much more. The Department of Anesthesiology of the De La Salle University Medical Center provides anesthesia to roughly 5,000 surgical and non-surgical cases annually. We cater to the different surgical specialties like general surgery, neurosurgery, cardiothoracic surgery, orthopedic, eye, ENT, obstetrics, and many more. Central to what we do as anesthesiologists is a topic that is very important. It is the first step in the perioperative management of a surgical patient, and that is the preoperative evaluation. Hello, my name is Dr. Balmores. I'm one of 20 anesthetic consultants, together with 18 anesthetic trainees in the department. Welcome to the first anesthetic lecture of 2019-2020. But before we start, let me tell you about our learning objectives for this topic. The first is to describe and understand the practice of anesthesiology, to describe the importance of preoperative evaluation, understand the components of the preoperative evaluation, conduct a preoperative evaluation on a standardized patient, and formulate a sound anesthetic plan on a given standardized patient. So numbers 4 and 5 will be done face-to-face on the 25th. What are our preoperative evaluation goals? First is to ensure that patients can safely tolerate anesthesia and surgery. Also to mitigate risk and promote efficiency and reduce costs. So what is preoperative evaluation? It is the process of clinical assessment that precedes the delivery of anesthesia care for surgery and for non-surgical procedures. It is an American Society of Anesthesiologists mandated and Joint Commission on Accreditation of Healthcare Organizations mandated responsibility that determines whether medical conditions are optimized and seeks to decrease risks for perioperative morbidity when possible. For non-emergency cases, it is ideal that all patients are seen by the anesthesiologist days before the surgical procedure, preferably in the hospital's preoperative clinic. What are the benefits of the preoperative evaluation? For the patient, it is an opportunity to meet their anesthesia provider, thereby reduce anxiety by offering personalized comfort and care. Education regarding different anesthetic options, intra-op and post-op, analgesia. It is also an opportunity to ask questions or clarify certain issues regarding anesthesia. And this is also the time to discuss medications, which ones they should continue or discontinue. For the anesthesiologist, the doctor can learn of patients' medical conditions which may influence anesthetic management. They can estimate the level of risk for every patient during this pre-op visit. It also allows optimization of the patient's medical condition by collaborating with other medical specialties like cardiologists, pulmonologists, etc. And through the pre-op evaluation, the doctor can devise an anesthetic plan prior to the day of surgery and discuss these options with the patient. And also, this ensures that they understand, or the patient understands, their own individual risk so that they can make an informed decision about whether to proceed to surgery. Also can plan discharge. So conducting a preoperative evaluation is based on the premise that it will modify patient care and improve outcome. For the surgeon and the hospital, it can decrease the cost of perioperative care. It can also improve the efficiency on day of surgery, thereby decreasing the number of cancellations and delay for surgery. The pre-anesthesia evaluation clinic, or the PAEC as we call it in the hospital, is a specialty clinic where patients are evaluated before surgery to establish a database upon which risk assessment and perioperative care management decisions can be made. Decisions like proceeding with surgery, delaying the surgery for optimization. We also do our pre-op visits in the wards for patients already admitted. This is an overview of the preoperative evaluation. We will talk about surgical patient. We will define the urgency of the procedure. And then we'll talk about history, physical examination, and laboratories. And then we'll talk about preoperative outcome, or what we hope to achieve at the end of the pre-op visit. And then we will make an anesthetic plan. For the surgical patient, this determines the urgency of the surgical procedure. So we do have 4 types of procedures: the elective, time-sensitive, urgent, and emergency. For elective cases, these are procedures that are planned at patient or surgeon's convenience, and the timing can be up to a year, and all procedures that can be planned in advance. For time-sensitive procedures, these are like stable but requires intervention. Timing is not 1 year, but only days to weeks. Examples of which are tendon and nerve injuries, or nerve injuries, and cancer procedures. For urgent, these are procedures that need to be done within 6 to 24 hours. These are conditions that threaten life, limb, or organ. Examples of which are perforated bowel, compound fracture, and eye injury. Now, for emergency cases, these has to be done less than 6 hours, or within 6 hours. These are life or limb or organ-saving procedures, examples of which are ruptured aortic aneurysm, major trauma to the thorax or abdomen, acute increases in ICP or intracranial pressure. Cesarean section is also an emergency. So the closer the timing to the main surgical point, the shorter the timing and the preparation that is allowed. So for elective, like 1 year, time sensitive days to weeks, urgent is 6 to 24, emergency less than 6 hours. Now we go to the history. So a medical history, I'm sure you're familiar with this because you have been doing this during your physical diagnosis subject. It's sort of similar but different. And I'll show you the similarities and differences. So on the left side is the medical patient for medical management, surgical patient for preoperative evaluation on the right side. So for medical patients usually come with a chief complaint and the doctor doesn't really know what the patient has yet. So he or she will work around and try to figure out what the patient has by going through the history of present illness, past medical history, personal social, and review of systems, etc. And hopefully to arrive at the disease process and hopefully manage that disease. Whereas for the surgical patient going for a preoperative evaluation, they already have a diagnosis and they just come to our clinics for preoperative evaluation. So again, they go through the history of present illness, basically the nature of illness or injury. We go through that and look for comorbidities in the past medical history, personal, social, and review of systems, and hopefully to make a decision whether to proceed with surgery, delay, and optimize. So we've done the surgical patient, and now we'll go through the history and physical examination. So again, we'll run through the urgency or the different types of surgery. For a history, for urgent and emergency cases, like I said, you're pressed for time with these patients, so you have limited time to prepare. They require a more abbreviated evaluation, which therefore increases anesthetic morbidity and mortality. So the anesthesiologist and the surgeon must weigh the risk of morbidity of operative delay versus benefits of establishing associated diagnosis that can influence patient management. For time-sensitive and elective surgeries, basically we look at the nature of illness or injury. So for example, an acute appendicitis, we have a look at the patient's overall status, hydration, hemodynamic stability, and all that. And we go through the past medical history and look for comorbidities, the presence or absence of comorbidities. So my suggestions for you guys is to go by organ system. Say like this. For the CNS, you look for stroke or trauma to the head. For the cardiovascular, you look for hypertension, coronary artery disease, arrhythmias, congenital heart diseases. For the GIT or metabolic, you look for peptic ulcer disease, a history of reflux disease, diabetes, etc. For the pulmonary, you look for asthma, COPD, carcinoma, PTB, liver, look for hepatitis, carcinoma, and kidneys, you look for kidney injury or chronic kidney disease. So you basically look for end organ damage if the patient has one of those comorbidities and determine the stability of the disease process. And you decide later on if the patient needs more investigation and or referral to another specialist. And then you go through the personal and social history, smoking or drinking alcohol. This can affect your anesthetic management as well. And this is important. If the patient has previous anesthetics or surgery, you look for side effects from anesthesia like post-op nausea and vomiting, a difficult airway, or sometimes they mention allergy, and you need to dig some more and rule out malignant hyperthermia. And you ask for medication allergies. We now go to physical examination. The airway examination is composed of two, the history and physical examination. So for the history, if the patient has previous anesthetics and through your history, they mention about sore throat, chipped tooth, lip and tongue laceration, gum injury, then there is a high probability that these patients had difficulty in intubation and has a difficult airway. So you need to prepare for this. For the actual airway examination, there are multiple types of examination. The interincisor gap or the mouth opening, mandible and jaw protrusion. The lower jaw should go beyond the upper jaw. Extension of the cervical spine. This just determines the flexibility of the neck. Thyromental and sternomental distance. And the most common examination that we do is the Mallampati scoring. I will not go through each of the class. You can just read about this. But basically, how we do this is we ask patients to sit up, open their mouth as wide as they can, stick out their tongue without any sound. And then there are predictors of difficult mask ventilation. So patients more than 55 years old, patients with beard can have problems with mask ventilations, as you can see here. So we need to be more creative just to give oxygen to these patients. Morbidly obese patients are a challenge as well in terms of mask ventilation and the actual intubation itself. Patients with facial abnormalities can also pose a challenge. Those with receding chin and those without teeth can have problems as well during mask ventilation. So the rest of the physical examination is important as well, especially if you noted any comorbidities during your history taking. The examination of the neurologic system focuses on the patient's cognitive function, motor, and sensory function. This can be accomplished through simple observation. The patient's ability to answer health history questions practically ensures a normal mental status. The neurologic examination may be cursory in healthy patients or extensive in patients with coexisting disease. Testing strength, reflexes, and sensation may be important in patients if the anesthetic plan or surgical procedure may result in a change in the condition. For the cardiovascular system, the examination of the CVS should include blood pressure, measuring both arms when appropriate. The anesthesiologist should take into account the effects of preoperative anxiety and may want a record of resting blood pressure measurements. Persistently elevated blood pressure pre-induction with associated symptoms like headache, chest pain, arrhythmia may warrant further investigation and likely cancellation of surgery. Auscultation of the heart is performed, specifically looking for a murmur radiating to the carotids, suggestive of aortic stenosis, abnormal rhythms, or a gallop suggestive of heart failure. The presence of bruits over the carotid arteries would warrant further workup to determine the risk of stroke. The extremities should also be examined for the presence of peripheral cardiovascular disease. Physical examination of the chest should assess the respiratory rate as well as the chest incursion, use of accessory muscles, color of the nail, and the patient's ability to carry on a conversation or to walk without dyspnea. Auscultation should be used to detect decreased breath sounds, wheezing, stridor, or rales. When you look for hematologic abnormalities in patients, you look for petechiae, bruising, and clinical evidence of anemia. The presence of petechiae or bruising may indicate a derangement of platelet function, which can cause bleeding intraoperatively. It is important to investigate such findings and correct whatever abnormalities identified. So now you've gone through the history, the physical examination, and then now you need to decide what types of laboratory examination you need to request for this patient. Preoperative testing, like chest x-rays, ECG, CBC urinalysis, is often performed before surgical procedures. These investigations can be helpful to stratify risk, direct anesthetic choices and guide postoperative management, but often are obtained because of protocol rather than medical necessity. The decision to order preoperative tests should be guided by the patient's clinical history, comorbidities, and physical examination findings. Patients with signs or symptoms of active cardiovascular disease should be evaluated with appropriate testing regardless of their preoperative status. This is just a basic summary of preoperative lab tests, which I got from the American Academy of Family Physicians. So here they talk about the necessity of requesting laboratories, ECG, chest x-rays, urinalysis, electrolytes and creatinine, sugar, CBC, and coagulation profiles. But we're just going to talk about two examinations, the ECG and chest x-ray. For the ECG, how do you decide whether this patient needs an ECG or not? We classify the procedure according to risk. Low-risk procedure are ambulatory surgeries like breast surgery, endoscopic procedure, superficial procedures, cataract surgery. High risk, which entails more than 5% of risk of cardiac death and non-fatal myocardial infarction, are those that involve the aortic and major vascular surgery, peripheral vascular surgery as well. The intermediate, which entails 1 to 5% risk, are intraperitoneal and intrathoracic surgery, carotid and arterectomy, head and neck surgery, orthopedic surgery, and prostate surgery. For low risk procedures, ECG is not recommended. Now for high risk procedures, yes, they all should have an ECG or a baseline ECG regardless. Now the gray area, the intermediate, these patients are in the middle. So how do we decide whether this patient need ECG or not? So we look for risk stratification. We use the revised cardiac risk index. So these include 5 clinical risk factors and 1 procedural risk factors. So ischemic heart disease, congestive heart disease, cerebrovascular disease, diabetes, creatinine more than 2 milligram per deciliter, and a procedural risk of suprainguinal vascular surgery, intrathoracic or intra-abdominal surgery. So for high-risk procedure, again, yes, they do need ECG regardless. For intermediate, the gray zone, if they have 1 clinical risk, then they will need an ECG. But for low-risk procedures, you don't need an ECG for that. So this is just an algorithm on how to do it. For chest x-rays, 5 institutes, the Institute for Clinical Systems Improvement, the American Society of Anesthesiology, and American College of Physicians and Radiology, and the National Institute for Clinical Excellence in the UK, they all agree that routine preoperative chest radiography in asymptomatic, otherwise healthy individual is not recommended. For the rest of the laboratory examinations, please refer to the table mentioned in the previous slide. Now we go to risk stratification. Why is this important? It is important because it provides information to assess the probability of complications and provide an estimation of risk. This can guide you on how you will prepare the patient perioperatively and how you will explain the situation to the patient's relatives in terms of risk and possible outcome. So the most common tool we use to stratify surgical patients are the one formulated by the American Society of Anesthesiologists, which is the ASA Physical Status Classification. It's they classify it from 1 to 6, plus E for emergency cases, 1 being for normal, healthy patients, 2, patient with mild systemic disease, 3, patient with severe systemic disease, so forth and so on until you reach physical status 6. These are brain dead patient, declared brain dead patient whose organs are being removed for donor purposes. So you can have a physical status 1E. That means a normal patient having an emergency surgery. Another risk stratification is the Lee's Revised Cardiac Risk Index. This is an update of the Goldman Cardiac Risk Index and is a validated method to assign perioperative risk using readily available clinical variables. As mentioned before, it includes 5 clinical risk factors plus 1 procedural risk factor. The 5 clinical risk factors include ischemic heart disease, congestive heart failure, cerebrovascular disease, diabetes requiring insulin, creatinine level of more than 2 milligrams per deciliter, and the procedural risk factor like suprainguinal vascular surgery, intrathoracic or intra-abdominal surgery. So each of these risk factors is allotted 1 point each. If a patient does not have any of those risk factors, they still have a risk of MACE or major adverse cardiac event of 0.4%. MACE includes myocardial infarction, pulmonary edema, ventricular fibrillation, primary cardiac arrest, and complete heart block. So if patients have 1 risk factor, they have a risk of MACE of 0.9%. If they have more than 3, they get more than 11% risk of MACE. Other risk predictors like the American College of Surgeons NSQIP or the National Surgical Quality Improvement Program. This is available in this website. After getting all the pertinent information with regards to a patient's case, and after you have risk stratified the patient, the anesthesiologist will then make an anesthetic plan based on all the information gathered. This will all depend on the surgical procedure, the patient's medical condition, and the patient preference. In an elective surgical procedure, there is one decision the anesthesiologist must make during the preoperative evaluation. He or she must decide whether the patient is fit for surgery or not. If the patient is not fit for surgery, then optimization is the next step. Patients that need further investigation and management can be referred to other specialties concerned. This is just a diagram on what I mentioned earlier. So if a patient is fit, they go through anesthetic options, whether a GA, a regional, a sedation, whatever. And then we explain the risks, options, possible complications, and we get their informed consent. And then we prepare these patients psychologically and pharmacologically. It is important to fast this patient because fasting can prevent anesthetic problems from happening, such as pulmonary aspiration, which can prolong hospital stay and increase morbidity. Fasting guidelines formulated by the ASA includes clear liquids with a minimum of 2 hours, breast milk 4 hours minimum, infant formula 6 hours, non-human milk and light meal should have 6 hours of fasting. We can also give premedications to these patients. We give prokinetics to increase gastric emptying time and reduce gastric aspiration. We provide H2 blockers, proton pump inhibitors, or antacids. If the patient is really anxious, we can opt to give them benzodiazepines or just, talk to them, explain the procedures and, calm them down. Sometimes and most of the time they're okay with that. And if patients have their own medications like antihypertensive, we usually give that medications to them the morning of surgery. But if they're diabetic, we omit the morning dose. So in summary, we have described and hopefully understood the practice of anesthesiology. We have described the importance of preoperative evaluation, and hopefully you understood the components of the preoperative evaluation. And during our face-to-face meeting on the 25th, you will conduct a preoperative evaluation on a standardized patient, and hopefully you will formulate a sound anesthetic plan, and then you will present that in a plenary. So I will see you on the 25th. As mentioned, I will group you into 6 groups, and we will assign 1 patient each, 1 standardized patient each. So hopefully you will all do a preoperative evaluation in these patients for 15 minutes or for 20 minutes, and then present each